Let's try that. Oh, there you go. Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Farden. I'm the chair and organiser of Grand Rounds. Thanks very much for coming. It's nice to be back. I've had a couple of weeks gap from coming to Grand Rounds, so I'm grateful for those people who stood in for me last week and the week before to chair this whilst I was gallivanting around in America. So thanks to them. And we're straight back into things with a seasonal topic this week. When the slide up here will give you some idea of what we're talking about. We're going to have Danny Chandler and Jane Forbes are here from Public Health to talk about influenza. And I get the feeling that I might be used as a stooge for something halfway through this presentation, so don't take too much glee in watching me be stabbed in the arm. But first, before we do that, Vicky Alexander from the paediatric team is here. She'd like to just announce an exciting thing. So, Vicky, you get a couple of minutes here, and then we'll go straight to Danny.
Thanks very much, Tom. I took this opportunity to just gate crash, really to just advertise an event that's coming up in November, 21st of November. Tayside Healthcare Arts Trust are doing a charity art auction. And this has been a highly successful event in the past. It's run at Discovery Point. It's great fun. Lots of affordable art from local artists, silent auction and a main auction. And Tom has kindly agreed that he'll distribute the flyer around everybody. For those of you that don't know about Tayside Healthcare Arts Trust, we're a partnership organisation with NHS Tayside, doing mainly participatory programmes with people with long-term conditions. So dancing with dementia, we've done singing with choir with airways problems, COPD, creative writing groups with people with acquired brain injury, and a whole mix of different things, including collaboration with the Scottish National Orchestra, which has been fantastic. I get the privilege of being able to go to the celebratory programmes. I can't say enough about how people value the opportunity to use arts to improve their health and well-being. The art auction raises a lot of money to support the organisation. I'm sure all of you have a space that's just waiting for a new piece of artwork. And 21st November, Discovery Point. And as I say, Tom will send the invite round as Eventbrite tickets. So anybody who wants to get hold of me, I can get tickets for you as well. So thanks very much, Tom.
Okay.
Plug over.
Nice to know. Right. Just a bit of in and a bit out. The other thing before we get started, you'll have read my wonderfully entertaining and informative email, as you do every week. But somebody who did read it was Tom McDonnell, who can't be here today, and he's emailed me this morning to say I must mention on his behalf that I talked about this study which was published this week about giving antihypertensive drugs in the evening rather than the morning, and it showed a remarkable improvement, a 50% reduction in outcomes if you give drugs in the evening rather than the morning. It's an incredible result. Tom was very keen to point out that we in Tayside have been doing a similar study for a number of years. Tim, you'll probably tell me how long. For 3 years, called the TIME study, which has been looking at exactly the same thing. And I think BHF, the British Heart Foundation, actually asked us to do that study here because they didn't quite believe the results of preliminary studies that were done in Spain. So if you are interested in that sort of thing, then Tom McDonnell is very keen to talk to you because that study is ongoing, and we'll see if those results from the large study can be replicated in our large cohort. And the other thing that I must mention, and I mentioned it in the email, but I'll mention it now so it goes on video forever, is how proud we are of Sarah Martins de Silva, who has made the top 100 women on the BBC top 100 women's list, and that's a real achievement for her. Something's beeping, it's not me. That's a real achievement for her and a testament to the work that she's done here in Tayside. And she is an ex-Grand Round speaker, so I'm going to drag her back in the summer or in the spring so she can tell us an update on what she's been up to. Anyway, that's the parish notices, as it were, so I'll just get on and introduce Danny, who's going to talk along with Jane a little bit. You're not just going to stab me, there's going to be some talk as well. And they're going to talk us all about flu.
Thank you, Tom. Hi, everybody. For those who I've not met before, I'm Daniel Chandler. I'm a consultant in public health. and part of my role is involved in organising and coordinating vaccination programmes across Tayside, one of which is obviously flu, and so we're here today to talk about a very topical subject, which is the flu vaccine programme, thinking particularly about the staff, NHS staff aspect of that. So this picture, I hope, gives you a bit of a flavour of why it's important to think about flu, think about it as a highly infectious and transmissible agent, but I promise there's no more unpleasant photos like this over the rest of the course of my talk today. I am assisted today by Jane, as Tom's mentioned. Jane is our vaccine programmes manager, and she's going to do some of the talking with me as a bit of a double act. We've also got, sitting side by side with Jane, David, who's also a vaccine programme manager in our team, and right at the back, Alison, who's a project officer. So we are very much a team, and we work with colleagues across the organisation to coordinate and deliver the programmes I'm going to be talking about. So we'll come on to some of the detail of how that all functions shortly, but first of all, if I can get myself set up. Introductory slide, over. So to talk about the background briefly in terms of the epidemiology and virology of flu. There'll be people in the room who are more qualified to talk about virology certainly than I am, but hopefully this will give you a bit of revision or a bit of a summary for those who maybe aren't as familiar. So briefly, at UK level, flu is thought to generate hundreds of thousands of GP consultations every year, obviously a huge impact on overall NHS workloads and activity. From there, tens of thousands of hospitalisations across the UK, and 4,000 to 14,000 deaths attributable to flu in the UK every year. That's an estimate. It's difficult to get concrete figures because many cases of flu are never microbiologically diagnosed and confirmed, but those are the best estimates, and the average is around 8,000 deaths a year. So obviously it's a significant public health issue, and that's why we have a vaccination programme. In terms of the epidemiology, obviously it's seasonal. There tends to be an 8 to 10 week window each year or each season where the activity peaks, but that in itself is quite mobile. It can be any time from late September, early October, up until the most sort of common on average is into January, late January, February. But that will be variable in terms of the length and the peak, the scale of the activity will change year to year. Within that, we can have additional issues in terms of outbreaks and epidemics over and above the average levels of activity, and that's caused by primarily flu A being a highly antigenically labile virus. So there are two surface antigens that are principally involved in that issue. You may be familiar with the H and the N nomenclature. And so they are both subject to both antigenic drift, which occurs progressively year to year. It's minor changes in the molecules that make up those antigens, and that is the reason why you need a new and a different vaccine formulation for each season. Over and above that, there is antigenic shift, which is a more major level of change in the antigens, and that occurs more sporadically, and that's the cause of more extensive outbreaks and epidemics, and at the worst case level, pandemics, which I'll touch on again briefly shortly. There's also influenza B virus, which are strains that tend to undergo less significant drift antigenically, and they cause less severe disease, more typically affecting children and often subclinical. So this is just a picture illustrating what I've been summarising, the peak that you will see in a typical flu season, which can be quite varied in terms of the scale of it. So this is Scottish data. It's representing the most recent data available from flu surveillance activity. And it shows 4 selected years, so the 3 most recent, or the 2 most recent plus the current season, which is in red. Obviously, we're only just getting started. And the 2010-2011 season, which is the last really big peak we had. And you'll see that 2 years ago, the dark blue line there, we obviously had a worse than a typical season, but it wasn't on the same scale as 8 or 10 years prior to that. And the position on the timeline when those peaks occur obviously varies, and you can see that. The most recent season, 2018-19, it was relatively mild. We had a sort of a duo of peaks, the second one being a bit wider in terms of time, and that was around week 4 to 6 of the year, so mid to late January and into February. That is replicated, so I should have said that's consultations for flu-like illness in practices. That's one arm of surveillance that takes place at Scotland and UK level. This is another aspect of surveillance. This is English data, and it's hospitalisations due to flu, diagnosed and confirmed as flu. And again, you've got, for the most recent year, the black line and the red bars showing that peak around mid to late January. And the season before is also shown on there, which is a slightly earlier peak in activity. So that's a sort of typical season or typical year or range of typical years. There are also much more occasionally genuine pandemics, and this is a very classic photo of, does anyone know what the pandemic was known as that this photo comes from? Spanish flu, yeah. So that was in what year? 1918, yeah. So in terms of documented or recorded history, we have 4 pandemics that have been verified, going back to around 100 years ago from this year. So that was Spanish flu, and that caused worldwide around 20 to 50 million deaths, it's estimated. So obviously a huge worldwide public health impact, more deaths than were caused by World War I, although undoubtedly the impact in terms of general health and well-being of the war and the survivors and people's general levels of health and nutrition and so on would have been a key factor in the scale of deaths and the scale of incidents from that pandemic. Then we jump to the middle of the last century. We've now picked on the Asians and Hong Kong as being the people who are at fault. And you can see there's a sort of perhaps slightly outdated approach to attributing blame or fault for these pandemics that it's certainly not to do with us in the UK, but they are absolutely global phenomenons, and it tends to be where the first few cases are recognised or the first strain is detected that then gets pinned on as being the name, the colloquial name of that pandemic. You can see from the different pandemics, so we go from 57 to 68, they've all got different H and N antigen profiles, and latterly in 2009 we had what is the most recent confirmed pandemic, which was known as swine flu. So we've moved on from blaming parts of the world to blaming other species, which is perhaps a form of progress. And the scale of deaths from each pandemic has obviously quite markedly dropped down over that 100 years or so, which I think is a reflection of gains in terms of public health, gains in terms of general population health and well-being, and also the measures we're able to bring to bear in terms of preventing and managing and reducing the impact and the severity of any given flu pandemic. What will be the next one? We don't know. When will it happen? We don't know. There's no real way to predict, but certainly the WHO and national surveillance organisations are keenly watching a whole number of different strains, but in particular H5N1 and H7N9, which are both variations of avian flu, bird flu, which often gets talked about in sort of general media circles as possibly being the next big threat in terms of a global pandemic. And that's because of the interface between humans and animals being where there's the opportunity for that sort of antigenic shift to occur within the virus and for it to gain pandemic potential. So it's a case of watch this space and being as prepared as we can as a system and as a country and as a global community for when that pandemic that we're due, we don't know when, but whenever it happens, we need to be prepared. So being prepared against flu, both at the pandemic level, but also the more mundane annual seasonal programme of preparedness. It involves, for everybody in work and at home, general good hygiene practice, hand washing, cleaning of surfaces, cough and sneeze etiquette, putting your tissues straight into the bin, and if you are symptomatic, then being sensible about remaining at home, not going to work, having good occupational health policies, following those, and also vaccination, of course, is crucial, which I'm here to talk more about. That's prevention. that you will undoubtedly get people becoming well with flu every year, no matter how good your preventative strategies. So we then need to think about case management, and in terms of reducing onward transmission, both in hospital and community contexts. So that's about good infection control precautions, limiting visits to people who are infectious, early detection, early diagnosis, point of care testing. There's good work happening both from last year and continuing on to this year in 9 Wells to have point of care testing for flu and respiratory viruses more available to help with risk assessing and managing patients with respiratory infections appropriately. And for those who are eligible or for whom it's indicated, antiviral treatment can reduce the severity and the duration of illness and help to prevent onward spread. So as part of all that preparation, we also undertake surveillance. And again, this happens year to year at Scotland and UK and global levels. There's a report like this, which is produced weekly. This is Scottish data, and obviously there's a lot of detail there, but you have the nice visual signifiers of the fact that at the moment, current levels of activity are stable and at low or baseline levels. But over the course of the season, those will start to pick up, and we try and make sure we keep on top of the latest information and relay that to clinicians and others involved in service planning. So that covers both flu and norovirus and other seasonal respiratory infections and gastroenteritis type illnesses. It's based on GP presentations, it's based on lab confirmations and hospital diagnoses. So it's quite an extensive programme which has been built up over time. So that allows us to be prepared as much as it's possible to be and to get ahead of the curve. Another way that people often think about preparing and being able to predict or anticipate what will happen in a given flu season is to look at what's going on in the southern hemisphere during the previous 6 months. Obviously their winter is in the midst of our summer, and so their flu season is 6 months roughly more or less shifted along the curve over the course of the year. So this is the most recent data available from Australia, showing the current flu season in red, or the one they've now coming to the end of, and comparing it to previous years. And that's based on initially their lab-confirmed cases, and a rather similar picture based on hospitalisations at Sentinel hospitals. And the key take-home lesson there, I think, is obviously that the peak of activity occurred much earlier than has been seen over the past 5 or 6 years in Australia this year. So the implication or the assumption might be, therefore, that we need to be ready for an early flu season here in the UK this year. Is that definitely going to happen? Well, we can't be sure. So we can certainly analyse and look at what the different facets of the Australian experience were in the last 6 months. As I've said, it occurred earlier than is typical, but other than that, it wasn't a notably severe or difficult flu season for them. They had a low level of severity as measured by numbers of ICU cases and deaths. Hospital occupancy and work absences in the community were low to moderate, and it was a reasonably good match between the vaccine and the circulating strains based on preliminary data. However, Australia is only just one country in the whole of the Southern Hemisphere's annual flu season. They're probably ahead of most, if not all, of their neighbours in terms of the extensiveness of their surveillance and the reporting on it. We tend to access it more easily here because it's an English-speaking country, but there'll be the same level of activity in countries in South America, Southern Africa and so on. And it won't be a universal experience being the same across the Southern Hemisphere. We know that the UK epidemiology of flu isn't always the same as elsewhere in Europe. There has been studies done which have suggested that what happens in Australia is on average a good predictor of what will happen in our part of the world over the following 6 months, around half the time. So the key takeaway message there is that we need to be prepared for all eventualities. It's helpful to be able to anticipate what might happen, but regardless of what's been happening in the Southern Hemisphere, we should make every effort to be as well prepared as possible every year. And the same applies for them, so they'll be tracking in the Southern Hemisphere what's going to be happening over the next few months for us, and they'll feed that into their surveillance and planning for the next winter in Australia. So a part of being prepared is obviously vaccinating healthcare workers. And as you'll be familiar with, the CMO and CNO, as well as the Chief Pharmaceutical Officer, are all very clear that this is an expected and a normal part of the good practice that any healthcare worker should be expected to engage in, particularly for those who work in areas where patients are cared for who are in the most vulnerable groups, and there's a list of those there. The target has been set at the same level for a number of years, and that is to vaccinate 60% of frontline staff, particularly in those high-risk areas, and to make the vaccine as convenient and accessible as possible, and that's where I come in, and more particularly Jane and our colleagues in delivering the flu staff programme come in. So a slight diversion, just briefly to talk about the flu vaccination more generally in terms of the background. We've had a flu vaccine available since around the late 1960s in the UK. The first people to be recommended to receive it were people in clinical risk groups. It was then extended in the year 2000 to everyone aged 65 plus, and then over the next 10 to 15 years we had women who are pregnant and people who have morbid obesity also added in as target groups. And then from 2013 there began the phased introduction of flu vaccination for all 2 to 5-year-olds and all primary school aged children across Scotland and the UK. And that was based on the licensing and availability of a vaccine which is different to most flu vaccines, certainly the ones that adults receive, in that this is a live attenuated vaccine and it's a nasal vaccine, so it's a squirt of spray up the nose for young children. It's the acceptability of that to children and parents, the fact that it's a live vaccine, so it tends to be more effective, like for like. That was the threshold that led to the expert advice that this should be a programme introduced for children as well. In terms of occupational programmes, the NHS Staff Flu programme is an occupational health programme, and it's not limited to healthcare workers. All employers who have healthcare workers, health and social care staff, should all make provision to offer vaccination as part of their responsibilities under the Health and Safety at Work Act. And the date that goes back to is obviously 1974. I had a good look and I didn't manage to find out when we first in practice had staff flu vaccinations going on. Certainly it's at least 10 to 15 years that you can find data for, but there may be others in the room who have more of a feel for that than I do, how long we've been vaccinating staff. But I think certainly over the last 5 to 10 years, the amount of emphasis and focus and priority given to that programme, particularly from government and from health boards and on down, has increased significantly and accelerated perhaps by the experience with the swine flu pandemic, as was making people think of flu as a more salient and more prominent concern in terms of the need to be prepared. So as I've mentioned, there are quite a range of vaccines available to immunise against flu, but there's only one that is a live vaccine, all the others are inactivated, mostly prepared from embryonated hen's eggs, but cell-based production is an increasing component of the overall vaccine manufacturing programme. And that's in part driven by recent evidence that flu vaccine effectiveness is reducing because the virus strains, that the vaccine strains of the virus are adapting to being produced or grown in eggs, and that's impacting on levels of protection amongst the population that we're able to observe. So that's an area of ongoing research and development. In terms of what strains go into the vaccine, you may be familiar with this process. Again, every year WHO will pull together all the surveillance data and recommend for each hemisphere what should be the strains for inclusion. A lot of it is educated guesswork because the time course for preparing vaccines is months long, and so the decision has to be made obviously well in advance of the time point when we'll be able to detect for real what viruses are circulating in the community. And so it's variable as to how well the match is in any given year, but a lot of research and a lot of technical expertise goes into trying to get that as good as it can be. Traditionally, vaccines against flu would often be trivalent, but we're increasingly seeing quadrivalent. That's 2A strains and 2B strains, and also adjuvanted vaccines are now coming on stream as a core part of the national programme. this year and in recent years, you tend to get a mix of different products, different manufacturers, different valencies of the vaccines that are used within the programme, and that's mainly to do with the scale of the numbers of people we're offering the vaccine to and the production capacity of the manufacturers. It's not possible to produce any one single vaccine in the numbers needed to cover everybody, so there's judgment that's made each year as to how best to tailor and target individual vaccines. When you get your flu jab, it takes up to 2 weeks to achieve full protection for the immune response to peak. And so the earlier you can vaccinate people in the season, the better you can be sure of providing protection for when that peak of activity happens, when the strains start circulating. At best, you get up to 80% effectiveness when there's a good match to the level of strains. So that means it prevents flu in up to 80% of people who are vaccinated, compared to if they didn't have the vaccine, having then become into contact with the flu virus. But it's less effective in older adults due to immunosenescence, and that's part of the reason why children and other members of the community are recommended to get vaccination, because not only does it protect them, but it protects those around them, and for young children particularly, think about grandparents and family members who may be vulnerable. So it's a population health intervention, very, very much so. There is a lot of evidence available, some of better quality than others, but in terms of the value of staff vaccination, in particular NHS staff, there is evidence that it's a valid and an effective programme. So this is a brief rundown of some of that evidence. We know, first of all, that healthcare workers are at increased risk of becoming exposed to and becoming unwell with flu. Transmission of flu virus is observed between healthcare workers, and it may also then lead on to members of their own families and others around them being at risk, as well as those in a work setting. And we know that flu vaccination will reduce rates of lab-confirmed flu amongst healthy adults, which most healthcare workers will be. Transmission from healthcare workers to patients has been reported as being an important source of flu infection for patients in care settings. And many patients, particularly in a hospital setting, are likely to be a member of one of the risk groups, excuse me, which means they're more vulnerable, more likely to experience complications. Staff absenteeism is also an important consideration. Protecting workers protects the service. And there is limited evidence, but it's emerging that it can be shown that vaccinating healthcare workers does reduce patient morbidity and mortality. So that is the case for getting your flu vaccine as a healthcare worker. And I'm going to hand over to Jane shortly to really push that message and really encourage you, because Jane is a great advocate for the programme. But just before I get to that, to talk a bit about our own staff flu vaccination programme here and some of the recent history of it. Here you have the rates of vaccination by health board ranked for all Scottish territorial boards, with the orange column showing Scotland, the average figure for all boards, and that is 2015-16 data. So you can see clearly we were not doing very well. However, a lot of time and effort, a lot of energy, a lot of thinking and activity has been put into that once we realised as a system, as a service, that this was something that we couldn't sustain as being acceptable. We managed to move on last year to quite a substantial shift. So from 17% uptake to over 54%, and being higher than the Scottish average. And that's a shift that we've achieved within 3 years. And that just shows you the full trend over time. So Tayside is the light blue line, the darker blue, or the turquoise line is Tayside. The darker blue line is Scottish boards on average, and the faint grey lines are each individual health board. So you can see we kind of hit rock bottom in 2015-16. We didn't do much better the following year, but that was the start of sort of concerted effort, and we've managed to basically establish a straight line level of improvement, 17-18% increase in uptake over the past 2 seasons. So we're quite pleased with that. How did we do it? We applied a lot of the principles in this document which is a nice guideline about how to increase uptake for flu vaccine, not just for healthcare workers, but it does cover those that programme. But that guidance only came out in 2018, and we started our initiatives a year or two prior to that. So what did we do? We tried to assess and evaluate why we had fallen behind so far. First of all, issues of how well coordinated, the level of leadership involved, the capacity and resource that was allocated to the service, how well it was promoted, how accessible it was, and how effective we were in capturing data and reporting on staff who had had the vaccine. It's likely that the 17% figure that we had for that 2-year period from 2 or 3 years ago, that is an underestimate, but that was the recorded figure we had because of issues in terms of accurate data capture. So we tried to remedy all of those issues by applying learning both from internal evaluation of our own programme and from our peers in other boards and elsewhere as in terms of what best practice is. We established a dedicated planning group, which is chaired by Jane, public health led, but with input from pharmacy, from nursing leadership, clinical leadership, from other disciplines, communications. A whole range of colleagues sit behind this effort to plan and deliver a more effective flu programme for staff. We've improved the frequency and accessibility and visibility of our drop-in clinics. You'll hopefully have noticed this year and in previous years that we have clinics in the concourse at Ninewells, and we have similar clinics elsewhere dotted around Tayside where people can easily drop in as they're passing. We're advertising that as well as we can with regular communications updates. So increasing the promotion and making it more accessible is one of the key planks of our strategy. We've also established peer immunisers. So first in place 2 years ago with a greater number last year. This is for particularly nurses and other staff who work in clinical areas who find it difficult to get away from their responsibilities, understandably. If we have an immuniser, someone trained who's there on the ward who can opportunistically offer you a vaccine where you're working to minimise disruption, and that's been successful as well. We have flexibility. We can put clinics in place at short notice, on demand. We have roaming clinics, and we have also improved our data capture and reporting. Also important has been increased visibility and leadership at senior levels in terms of board directors, chief executive and so on have really concentrated in the last couple of years in terms of supporting and expecting us to do better. And we've linked into wider preparedness for winter that the board has developed systems and processes for across the whole range of issues that winter brings. And Elaine Henry's been a key colleague and support in terms of her leadership of that wider campaign to feed in the Staff Flu programme as part of that overall strategy. So I'm going to stop talking very shortly. I'm going to hand over to Jane, but just before I do, this gives you, for the last 2 years when we really started making a difference, the trends in terms of week by week, the uptake that we were able to capture up to the end of the flu campaign, so from early October up to the end of December. We don't have figures for this year as yet, as they're still coming through, but we'll try and reproduce this graph and start to issue weekly updates in terms of overall uptake so far. We think we're at around 1,400 doses administered, and that would take us to around 20% of the total workforce. So we're probably on a par with the curve for last year, around 20% or so towards the end of October. But we're going to keep working and hopefully exceed our overall level last year, and the red line gives you our key target for this year, which is to hit that 60% Scottish national target level. I'll skip over that briefly just to make the point that uptake varies quite widely between different staff groups. Happily, doctors are pretty good at getting their flu jab based on the data we gathered last year. Up to 82% uptake was the reported figure. So well done if you're a doctor. If you're a nurse, we had a good level of uptake, not quite at the same level. So that was at the overall nursing staff uptake was at 49%, so a bit below the overall average for Tayside, and that's one of our key areas for development this year, is to try and learn and implement strategies to make it easier and make it more persuasive for people in that professional group to get their vaccine. So as I've said, we've got wide variation between different groups and also localities within the Tayside workforce. We need to strengthen education and awareness. We've been doing that already, trying to deal with some of the myths that still persist around the flu vaccine. Changing culture so it becomes a normal part of your responsibility as a health professional, almost akin to hand washing. It's a key responsibility as part of your infection control practice and your protection of your patients. We've increased the number of clinics in our schedule for this year for drop-ins, and also increased the number of peer immunisers who are delivering the vaccine in the wards and clinical areas. And we are doing our best to balance all of that with the whole set of different flu vaccination programmes and other public health programmes that are particularly focused in terms of activity at this time of year. So this is where I say thank you for listening to me, giving you what might be a slightly dry overview of where we are and how we got there. And now it's over to Jane to give you the reasons why you should get your flu vaccine if you're not already persuaded.
I need to get my consent form. Oh dear, where's it gone?
I think Alison's got more.
Oh, I'll go get consent form. Carry on.
So why do we need to get the flu vaccine? As Danny's just said, as healthcare workers, you're more exposed to the flu, and also we have a responsibility to protect our patients as well. So flu, caused by the influenza virus, it's highly infectious, so we're coming into areas potentially carrying the flu that we can then pass on to patients, colleagues, other members of our own family as well. Spread by droplets, sneezing, hand-to-hand, infected surfaces as well. And as Danny's already described, there are different types of influenza. A virus and B virus are the two main ones that we're concerned about. The C virus influenza tends to cause more mild respiratory illnesses, but they can continually be changing, so that's the reason why we advocate that people come back year on year in order to get their flu vaccine. Complications of flu: bronchitis, ear infections, sinusitis, pneumonia, meningitis are all secondary complications of having the flu virus. There is more risk of death and serious illness in our high-risk groups, so our neonates, our pregnant women, older people, and those in our care with underlying health conditions. So what we don't want to do is come in as health professionals, be looking after patients, and inadvertently actually make them less healthy than when they come in the first place. The flu vaccine remains the best defence against the flu, and vaccination of health workers protects the workers and helps reduce the risk of spreading the flu to patients, our colleagues and our family members. My daughter has asthma, my husband's in a high-risk group, both my parents are in their 80s, and I work in this environment. It's kind of a no-brainer for me. Of course I'm going to come and get my flu vaccine. The NHS doesn't offer us anything very often for free, so yeah, I'll definitely come and get this one. As Danny said as well, the ambition for NHS across Scotland is a 60% uptake target for healthcare workers. This year in Tayside, we have a bit more ambitious target than that. We know that we've increased, so a couple of years ago we took public health came in to take on the leadership of the healthcare flu programme, and we managed to raise the uptake from 17% up to 34%, and so we doubled it. That was the aim and we did it. Last year that increased up to 54%. And so this year what we would like to see is not just a 60% target that we've got across Scotland. We actually want to get up to 65%. We have been bottom for quite a long time. It was really nice to come off the bottom rung last year. It was, yeah, if I got off the bottom, I was going to be really pleased. We don't just want to be up there this year, we want to be at the top. Okay, so we really are aiming high this year. We want everybody to come along and get their flu vaccines because we want to show that NHS Tayside really care about their staff, really care about their patients, and are really getting that message across as well. Again, as Danny has already said, the CMO letter, the message that we want to get across is that healthcare workers have got a duty to ensure that those in their care are safe and protected. And the key message for all of the flu programmes this year is trust the facts, as in the T-shirt. Trust the facts, get the vaccine. So we want to really promote that. Across the last few years when I've been doing flu vaccines and I've been in the clinics and people are coming along and they're saying, oh, I'm not getting that, I got the flu last year after I got the flu vaccine, oh, I was really ill, oh, it doesn't work anyway, oh, this doesn't make any difference. These are all the things that have perpetuated our low uptake rates. What we need to do is start to challenge that. So what are the facts about the flu? Flu is highly infectious. It can hit anyone. So it doesn't matter if you've never had the flu before. It doesn't mean you're not going to catch it this year. Symptoms come on very quickly as well. So, there's not always a big run-up in terms of that. And it may well be that you'll come in because you know what it's like. You're not feeling very well. You know that your area is a bit under pressure. So you come in with that virus and potentially you're going to spread that to others. Even if you have mild symptoms, you can still be carrying the flu. So we can still pass that on to other people. The flu vaccine doesn't contain live viruses. So if anybody tells you they got the flu from having their vaccine, fake news, sorry, doesn't happen. It's not a live vaccine. It can't give you the flu. So please challenge that if you hear any of your colleagues actually saying that. Patients with health conditions are 18 times more likely to die from the flu than those without a health condition. I think this was the one that really kind of went, oh, really? Seriously? Can't believe that. That really quite threw me. The last thing I want to do is give a patient the flu virus because I'm not feeling quite right, feeling under the weather, but know that I've got to come in because I don't want my colleagues to be under pressure. The best way to help detect the spread is to actually be vaccinated. And even healthy people can get the flu. It can still be serious. I don't know if any... Show of hands, who's had the flu ever? Oh, quite a few. That's probably because you're all healthcare workers and you're all exposed to it. So quite a few of you have had the flu. If you've had the flu, you do realise that it can be very serious and you feel absolutely rotten. Quite a few of the people who've come to the clinic so far have said they've come this year because they got the flu last year or they got the flu the year before. The year before, certainly, it was over Christmas and New Year seemed to be the big period where a lot of people got it, and it just ruined their whole holiday period for them. So don't put yourself through that. Make sure you come nice and early and get yourself vaccinated early on. Again, the message from the Chief Medical Officer is that all healthcare workers should have their flu vaccine. The other facts: it's quick, it's safe, and it's free. Yay, freebies. We love a freebie. We'll also give you a free pen and a free sticker. So there's more than just the flu jab that you're getting. Everybody loves a pen. We did used to give you sweets, but we don't do that anymore. So pens are always good. It is very quick. It's a very fine needle. It comes in a vaccine. Yes, you might have seen some of the queues that we've had from staff queuing up, but we get through that very, very quickly. There are a lot of clinics. If you do see a queue, go away, come back. Usually the queue's gone down, or come into one of our other clinics. If you can wait, then that's all the better. But the more people that can get vaccinated and come early on, then the better that is. Again, you have to be immunised every year because the virus does change constantly and immunity reduces over time. So if you're vaccinated this year, by the time we get into flu season next year, your immunity is beginning to wane from that. And this year's flu vaccine protects against 4 different strains. As Danny said, the vaccine that we're giving to staff this year
It's a quadrivalent vaccine, and it's the egg-based vaccine that we are offering to staff this year. For more information, you can go to the NES website, and there's lots of information on there. If you are looking after patients who have any queries, again, that's where we would be directing them to if they want more information on flu. What can you do as healthcare workers? First and foremost, get vaccinated. It's the best way to prevent increased spread of the flu. Champion the flu vaccine in your own areas. Go back to your own areas. Wear your sticker. Say, look, I've been for my vaccine. What have all you been doing? Have any of you been for vaccine? Who's not been vaccinated? Right, get along there. There's a clinic on today. So that's what we're expecting you as clinicians to go back and say in your own areas. Raise the awareness amongst your colleagues about how serious the flu can be as an illness to them and also to their patients. And give the people the facts about the flu. If people, say things like, I'm not getting the flu jab because they gave me the flu the last time, actually challenge that. Don't just say, oh, well, okay, that's fine. Be telling them that's not the case, that's not the reason that you got that. Probably what they got was a different virus that was circulating. Unfortunately, flu season is also the season of lots of respiratory viruses. And as soon as we stick a needle in somebody's arm, every single symptom they get from then on, from now into March, is all attributed to the flu virus and the flu vaccine, and it's not. So please do challenge if colleagues say to you, and actually, no, they're talking rubbish. Keep the conversation high about the flu. So when you go to your handovers, when you go to your safety briefs, when you go to any of your team meetings, make sure it's on the agenda. Has everybody here had their flu jab? If not, well, come on away, you go up the stairs. There's a clinic up there today. Or there's peer immunisers in your area. So-and-so is immunising. There's vaccines in the fridge. You can get that done here. We've got a couple of areas who got 100% vaccination rates of their staff last year. And that was down to the charge nurses in the areas really promoting the flu vaccine. And basically they were saying, if you're not vaccinated, you're not coming into my ward. So, get your sleeve up, get your vaccine done. So they really, really did champion it. We know it can be done, so, we need that to happen. We also can signpost staff, so as well as our clinics here, we've got clinics in RVH, we have clinics in King's Cross. There's clinics this year running in Carsview. We've got a clinic in Maryfield, and we've also organised a clinic in the dental hospital this year because dentists were one of the areas that were lower. We can organise clinics in other areas should people want that for next year. Please come back to us, request that, we can get something organised. But what we're also doing, and what has been really effective, and I think is what pushed us through that 50% barrier, was the peer immunisers in the clinical areas. Often what people will report is, we're just too busy, we're too busy to get away, we can't come away, we've seen your queues, nobody wants to spend their lunch break standing in a queue, do you? You're hungry, you've been working all day. So the peer immunisers in your area can actually vaccinate you, and you don't need to go away out of your clinical area, and that has been really, really effective. We don't just need to have nurses as peer immunisers, doctors can be peer immunisers too. If any of the medical staff do want to be peer immunisers, please come see me, send me an email or come along to the clinic and just ask, and we can get that organised. It does actually, put that sign out there from medical staff that this is an important thing to do. So please don't think it's just a nursing responsibility. As I said, the seasonal flu, it's the quadrivalent inactivated vaccine. You can find more information about that on our website. So we do have a public health immunisation website which has all of the information on there. And also we vaccinate using the PGD, and the PGD can be found on the pharmacy website as well. So if any of you are wanting to become a peer immuniser, that's where you find the information. The key messages that we want to give are that healthcare workers are at increased risk of developing flu. I think the research says that you're roughly about 3 times more likely, you're 3 times more exposed as a healthcare worker than the general public. Healthcare workers are also a key source of flu transmission, as Danny had already said from the research that's there, so you can pass it on. We don't want that to happen. Immunisation of healthcare workers is likely to reduce morbidity and mortality in patients. And it's also the best way to protect yourself. So it's the best way to protect your colleagues. If anybody was working a couple of years ago at Christmas and we had a whole load of staff off sick, we also had a whole load of patients coming in with respiratory illness and flu illnesses. So that combination of decreased staff with increased patient levels is not a good one. We want to avoid that at all costs. Information and resources. This is where you will find more information on influenza, on the vaccines, and on immunisations in general as well. So thank you very much for listening, and has anybody got any questions?
Does anyone have any questions? Comments? Hang on, Alex. Wait for a sec. Yes, it needs to be recorded. There you go.
Hi, thanks very much. Very, very interesting and very valuable information. I was just interested to see one of the last tables that you showed in terms of uptake. What you were saying, doctors were pretty good, but I noticed that for these other therapeutic, both clinical frontline and non-clinical frontline, they were achieving 100%. And so what was special about that, or what went right there versus other groups? It's just an interesting fact that you are achieving 100% with at least 2 groups of people.
Really good question. We probably don't know in detail exactly what we did so right. It's probably a lot to do with that group of professionals in themselves, their readiness to take on board the messages, their culture in terms of the willingness to get the vaccine, and the knowledge base that perhaps they're bringing to bear in those decisions they're taking. There's maybe a little bit of an artefact effect. We are using categories that are defined through the Health Protection Scotland data reporting protocol, which don't necessarily map precisely to HR categorisation of our workforce. So it's as best translated as it can be, but there may be a few percentage points that are attributable to that sort of level of error. But even within that, it's clear that is a group that has done a very good job of coming along to get their vaccination. It may be that they have a bit more time and a bit more scope in their typical working day. The sort of issues that Jane was talking about for people in busy clinical areas may feel less able to get away, or they've got other priorities, understandably, in terms of using break time. We probably need to do a bit more to understand some of the in-depth reasons, or to learn from what we can then apply from that group to other staff cohorts. I don't know if Jane, you might want to say a bit more about that.
I think probably the ability to get away from their work area is the key factor for that one. And as Danny said, some of the groupings in terms of what they want nationally compared to what our occupational health groupings are were a wee bit different, so it may not be completely accurate. One of the other things as well was that our data collection forum, some people didn't actually know what staff groups they work in, and that may have been one that they will have ticked because they weren't quite sure about it. It's amazing, nobody knew what directorate they worked in, or even sometimes what staff group they were in, so that was quite an eye-opener for her, and we've had to adjust our data collection forums because of that. So
it may be worth just making the point that I think pharmacy staff, pharmacists and support workers come into that heading, so they're a group who are well primed to be open to the the messages we're putting out there about the value of flu vaccination. I think psychologists and other sort of groups are in there as well. So it's people who are perhaps primed to already be willing and also able to get to the clinics, as we've said.
What was interesting about the uptake last year was it was the first year that frontline staff actually were higher in terms of uptake than non-frontline staff, because usually every year it's our non-frontline staff that are actually higher. So last year we actually changed that round a little bit, and that's the group that we really want to be targeting as our frontline staff.
So they've kind of caught up with and overtaken the clinical staff with the non-clinical counterparts, which is good, which is what we're hoping for.
Isn't it amazing that the group of people who literally are breathed on all day long in their working life, the dentists, have the worst uptake? There's something going on there, isn't there? Very strange.
And that could have been availability, so we've tried to address that this year as well. So, if anybody would like to see how easy and quick a flu vaccine is, we're going to demonstrate with our lovely victim volunteer.
Assistant.
I'll just go and get my consent form.
The longest bit is still
If you don't want to watch me, then just go. It's fine.
once you fill out the consent form, it's really quick after that.
Should also say we have a flu clinic on
the
this
other thing
afternoon.
is, if you haven't had your flu vaccine and you do want to have your flu vaccine, we're going to open our clinic on the concourse. So we do have a clinic today from 4 o'clock onwards, but we're going to open the clinic early so that you're not waiting in queues.
Yes, that's all fine.